as I mentioned, Ajay is here. Ajay, please go ahead with your presentation.
Okay, sir. Very good morning to all the panelists, and a special thanks to the Academy Director, Dr. Rajneesh, sir, for giving me another chance to speak on this podium. I am Dr. Ajay Pratap Singh from the Vitlanova Clinic, Lucknow and Gonda, and today my case for presentation is Shock the Rock and Leave Nothing Behind. It's a saphenous waist graft, Savior, in which we did an IVUS guided DCB for an ISR. It's in presentation. This is my patient. Uh, My patient is a 60-year-old male presented to OPD with chief complaints of exertional angina of an NYHE class 3, despite on guideline-directed medical treatment. He underwent angioplasty 8 years back, followed by a cabbage in which a Lima to LED was done, SVG to OM1 and PDA was done 7 years back on the background of angina on exertion. Then he again underwent an angioplasty 18 months back for the 99% stenosis of the SVG graft. On this time presentation, his ECG was normal. Echocardiography showed mild concentric left ventricular hypertrophy. There was no RW regional wall motion, abdomen or any valvular dysfunction. After considering the clinical condition, coronary angiography was done. These are the baseline coronary angiogram of the patient, which shows left dominant system with significant distal left main, 100% stenosis of the LAD stent, ISR. There was 95% stenosis of the circumflex artery. Lima to LAD was patent. Following that, we did an angiography of the SVG graft. As soon as we hooked it with the JR femoral, we can clearly see there was a 99% stenosis of type 1C by run ISR. Type 1B ISR, the patient was planned for intervention. JR4 French was hooked and was engaged. The SVG OM graft was pre-dilated with a 2.5 millimeters of semi-compliant balloon, followed by, because initially there was nothing was passing through the lesion. So despite trying everything, I wanted to do an pre-procedure, IVUS procedure first, but to my dismay, I have to dilate the lesion. Following that, we did an IVUS evaluation of the patient. This is the IVUS run of the patient, which shows slight under expansion of the stent. There was new atherosclerosis and some calcification, eccentric calcification of an arc of 180 degree present. Considering the clinical situation of this patient and all other options, we went for the algorithm, which was recently published in an European Society of Cardiology, where they have assessed that we have to first define the culprit lesion for an ISR. In our case, it was type 1B type in stent stenosis for the SVG graft stent. Then we have already assessed the severity and the length of the disease in orthogonal. And then we did IVUS imaging to understand what was the cause of this ISR. Following that, we used, there is a routine, we have to decide what debulking strategy we has to be used. Considering my patient and the anatomy, we are dealing with an saphenous vein graft, which are highly prone for no flow and slow flows. And as it was already stented, I was in fear to place a filter wire or anything. Patient was having angina. As soon as we have crossed the IVUS catheter, we pre-dilated. So considering all these situations and mechanical factors in which IVUS showed calcification also, near thrombosis also. So we went for an intravascular lithotripsy as an debulking. No, here we have chosen a 3.5 millimeter balloon IVL. We did 40 pulses. There was no significant slow flow and no flow in the artery. Following that, we took a drug-coated balloon because it was already stented with a 3.5 into 38 synergy Provost Premier stent. So we took a DCB of Protage and 3.5 30 millimeter, and it was easily deliverable despite being such a long balloon, because this balloon has a hydrophilic coating on it, which helps us for delivering this balloon at very tortuous or difficult places, because I was expecting significant difficulty for delivering such a long balloon in stent stenosis. We inflated the balloon. For inflation of DCB, I follow a criteria of 90 seconds inflation followed by 10-second gap and again 90 seconds inflation. The expansion of our DCB balloon in orthogonal views was adequate. There was no any kind of recoil or under expansion left because we had already pre-dilated and then we dilated the lesion with a cutting balloon. This is the post DCB IVUS run of my patient. After we have done the DCB with a 3.5 into 30, we can see there was well opposed and expanded stent. There was no significant under expansion left. The valve area at the minimum stent area, the MSA was of 10.93 millimeters square, and at the tightest point it was 10.83 millimeters. So this was the proximal segment. This was the distal segment. This was the proximal, and this was the. Following that, these are the final angiographic views of my patient. We can see it clearly. This is a beautiful. It looks like there was no lesion in this in my patient. We checked it in orthogonal views. There was no residual stenosis or recoil. Following that, these are the view. I was satisfied with the result. So the take-home message of my case is that in PCI with SVG is associated with high risk of major cardiovascular events at long term, mostly driven by high rates of repeat HPV vascularization. Up till 1/4 of the patients with SVG graft come back to us for presenting in one on the other complaints. SVG presents specific challenges as they are more prone to show high atherosclerotic burden, which are more friable and prone to embolization during PCI, leading to no reflow phenomena and potential significant myocardial damage. In addition to the walls of SVG are thinner than those of native coronary artery, increasing the risk of perforation during PCI. Hence, the option for rotablation was taken out, or orbital atherectomy was not used in this case. Already there was a stent, and I don't want to create some iatrogenic complication in this patient. So this case points out the use of intravascular lithotripsy along with a drug-coated balloon as a promising approach for managing calcified peristent SVG lesions, as in my case, showing potential for safe and effective revascularization with minimum complication. And to our knowledge, this is the only case up till now in India where IVL has been used in an ISR in an SVG graft followed by a DC. Thank you. Thank you, sir.
Thanks, Ajay. This was definitely wonderful. And I think somebody is asking a question. What was your anti-platelet strategy in this case? Ankit is asking.
Yes, sir. Sir, post DCB, sir, I have given the patient dual antiplatelet with a ticagrelor because if this is within 18 months, he has again presented his cholesterol and all lipid profile came out to be normal. And the previous stent was also implanted by me only, and 18 months back. And that time also we did IVUS evaluation, and there was no significant cause of neurothrombosis. Patient was compliant also, so I have switched to. This time I have discharged the patient with a prasugrel and aspirin combination, and I'm planning to switch it after 3 months to do an antiplatelet therapy again.
No, I think this is wonderfully done. This is wonderfully done. Few points before
Yes.
I'll take Karthikeyan also into this. One thing that this is a beautifully grafted. Somebody has done a beautiful CABG. This is sequential graft.
Yes, sir.
First is the obtuse marginal one, and then it is going to the dominant circuit seams, right?
Yes, sir.
So now it's a very big territory. It's a very big and enormous territory this graft is playing. So this was a tight ISR and a beautiful thinking that how can we avoid another stent in stent with the ISR. So yes, there was some calcium. IVL is a reasonable strategy, though I feel cutting balloon would have also done its job, 3.5 cutting balloon. But yes, IVL is even a step further than the cutting balloon. So there was some calcium, but not that extensive.
Yes.
Probably cutting balloon and IVL results would have been very matchable. But still, I endorse that IVL looks like a very good option. And then you have done a wonderful job. It looks a pristine artery after you have done this. And hardly anybody can say there was ISR. And your IVUS post procedure was also showing a very good MSA and very good artery. Normally, in ISRs, even after doing everything, you
Yes.
find lots of invaginations, lots of tissue inside, and you don't feel like leaving it like that. So probably this is a difference of a native artery ISR and a vein graft ISR.
Absolutely. Absolutely.
Vein graft ISR, neoatherosclerosis will not be that extensive. But in the end, I think it's a wonderful job, Ajay. You keep on doing. See, that's what the surprise is, that our young generation is always thinking, you know. So you guys are amazing, and I think continue to do that. Be innovative
And
in the best interest of a patient.
Yes.
That is the idea.
That's correct.
Karthikeyan, yeah,
Absolutely correctly pointed by you that IVL was, well, it might be that I was reserving it for that because the previous procedure was also done by me only. At that time also I did filter placement along with that angioplasty and IVUS and all that. And the stent expansion was absolutely wonderful in the last time also. So this time when this patient came out, I was not having any filter and I wanted to use cutting balloon. I did one inflation of cutting balloon and patient developed slow flow. Immediately I switched to IVL because I knew that IVL is going to create the cracks in the calcium also, and perilesional calcification, which is often not visible with IVUS, can also be dealt with IVL. That's why that was the only my rationale to use IVL in this. And I was having a fear that any other debunking strategy is going to lead to slow flow and all other complications. And I don't want to mangle and filter wire or a spider filter device through a stent in an SVG graft, which is already tortuous. So that these were my fears, hence I switched to IVL. And considering the end result, I thought that my decision was acceptable and it was a good result. And the difference that you have pointed for the SVG graft ISR and the native vessel ISR is very evident, and that was a very beautiful insight from you, sir. I kept on thinking of this, why this result is so good. So I think I also was thinking this only, that there is some mechanical difference between the graft ISR and an arterial ISR.
there has to be. There has to be. It's a different animal altogether,
Yes.
the graft and the native vessel. But then I think it's worthwhile. I'm not saying why IVL. IVL only is a cost factor, but otherwise, if somehow that cost is taken care by insurance, something, this definitely gives a better picture. So your end result is very good. It's very gratifying. So I think it's a good innovative thought. Karthikeyan, your few points.
Yes, sir. A nice case, really, sir. Actually, the lesion preparation, as you said, sir, it's the most important thing. Without, we have to start using all these, sir, IVL or ROTA with no hesitation, actually, sir. The more we start using those things in every other case, if required, actually, I think it will be more better, actually. The more we prepare the lesion, the easier it will be for the end result, sir. And, sir, we consider dual thrombotic therapy in this patient. Patient comes 18 months, Compass trial, they have given rivaroxaban along with your another antiplatelet.
See, we have already not, the previous stent was implanted 18 months back. Patient already switched to single antiplatelet therapy after 3 months. Now I have done DCB. DCB gives us an extra edge here. As in drug-coated balloon, we don't have to give dual antiplatelet therapy for 1 year or 2 years, considering the patient's age and all. So I have given him prasugrel along with aspirin, and my planning is to switch because I did this case 1.5 months back only. So I will be switching back to single antiplatelet again after 3 months. And that also I have given just because I was in fear, because didn't show any significant under expansion. So I was also in the pretext that there might be possible that this is an acute thrombotic lesion in my patient, which had led to this intervention from my side of DCB, or has created this problem. So not rivaroxaban, I'm not that comfortable. If this patient would have AF, atrial fibrillation along with that, then my 100% my first choice would have been rivaroxaban.
I want to know, sir, anyone has experience, right? Using, because the Compass trial came with a rate of 33 months of using rivaroxaban along with an antiplatelet. For these kind of cases with high ischemic risk, actually, starting this, have you tried with anyone patients?
Usually, I kept all these NOACs or rivaroxaban or apixaban I only use in patients with atrial fibrillation with undergoing PCI. No
I
other.
agree.
I
I
don't
agree
find
with
there will be
Ajay.
any.
And I think Karthikeyan question was also right. There is some data coming up where rivaroxaban with single antiplatelet, other single antiplatelet is being used in trials, and they are showing relatively good results also. But I think our guideline is that we stick to a double antiplatelets and a rivaroxaban if unduly thrombotic lesion, or there is some thrombus in the LV, or atrial fibrillation, then only we use it. But we require more data with only rivaroxaban and a single antiplatelet. Rupesh is also here. That's one point from Rupesh. Let's take it.
Sir, personally, like I have not started using like low dose rivaroxaban in combination with antiplatelets for pure CAD. As of now, I'm sticking to patients with atrial fibrillation. But in patients of atrial fibrillation, where we actually give triple therapy for initial 1 or 2 months, sometimes they are reasonably well tolerated. So I think it is a avenue which we should explore. Probably I will consider, especially in patients with graft PCI, like it can be tried. It is something which we should look into it. Definitely, I have not personally started it, but I think I will probably in the next patients, if it is a high thrombotic burden, I will try NOACs along with antibiotics.
Yeah. So I think that's what we stick to at the moment. Right, Karthikeyan? So I
Yes, sir.
think, yeah, we keep discussing all these points.